Good morning. Welcome to today's session. Now we are going to discuss about one of the neurological disorder or the cranial nerve disorder, that is trigeminal neuralgia. We'll be discussing about the definition, classification, etiology, pathogenesis, clinical features, diagnosis, and management of trigeminal neuralgia. As the name suggests, trigeminal neuralgia, it is the pain which is caused by the damaged or the irritated trigeminal nerve. Trigeminal nerve, as we all know, it is the fifth and the largest cranial nerve. It has mainly three branches, the ophthalmic, the maxillary, and the mandibular branch. And these branches is joining at the trigeminal ganglia. Of the three branches, the ophthalmic and the maxillary branch are the sensory branch, and mandibular branch has both sensory and motor fibers. Trigeminal neuralgia, which is also known as Tig-Dowler-Weix or Fothergill's disease, is a neuropathic disorder or one or more of the trigeminal nerves. Moving on to the definition, it is a sudden, usually unilateral, severe, brief stabbing pain in the distribution of one or more branches of the trigeminal nerve. So the main characteristic feature of the trigeminal nerve is the pain, and it is being explained, the type of pain or the characteristics of pain in the definition. This is sudden, usually unilateral, and severe stabbing pain in the distribution of one or more branches of the trigeminal nerve. Next, we'll be discussing about the classification. International Headache Society classified trigeminal neuralgia into two types. That is classical or the idiopathic as well as the symptomatic. So, telling about the characteristics feature of pain, both classical as well as symptomatic has the same characteristics of pain. That is, both are unilateral disorders and which is characterized by the brief electric shock like pain. And in case of a classical trigeminal neuralgia, it is abrupt in onset as well as the termination. And what is peculiar to symptomatic trigeminal neuralgia is that it is mainly caused by a demonstrable structural lesion other than vascular compression. The main etiological factors of trigeminal neuralgia is the vascular compression. So other than the vascular compression, it is also caused by the demonstrable structural lesion. Then regarding the etiological factors, as we already told, the main cause of the trigeminal neuralgia is the compression of the trigeminal nerve root. So this compression can be either due to any lesions or due to any artery or vein which is compressing the trigeminal nerve root. Then it can also be caused by the demyelinating disorders. So the examples for the demyelinating disorders include multiple sclerosis or any hereditary neuropathies like Charcot-Marie-Tooth disease. So these disorders are also the causes for trigeminal neuralgia. And it can also be caused because of any infiltrative disorders of trigeminal nerve root and ganglion. And it may be due to the carcinomatous or any perineural spread of head and neck cancer. So the infiltrative disorders can be due to any carcinomas in the brain, or it can be also due to a perineural spread of head and neck cancers. Then the other root causes may be the non-demyelinating lesions of bones and medulla. And it can also be caused because of the familial trigeminal neuralgia. So those persons who are having any history of trigeminal neuralgia, it can also be the cause for the trigeminal neuralgia. So these are the main etiological factors for trigeminal nerve root. Of this, the most commonest is the compression of the trigeminal nerve root due to any of the lesions or the artery or the vein. And there are certain triggering zones or triggers which will exacerbate the condition of trigeminal neuralgia. So these are otherwise called as the triggering zones, and it includes the shaving, during the time of shaving, while stroking your face, while eating, while drinking, while brushing your teeth, while talking, while putting on makeup, encountering a breeze, smile, even a light touch can exacerbate the condition. So these all are considered to be the triggering zones or triggers which will exacerbate the condition of trigeminal neuralgia. Next, we'll be moving on to the pathogenesis. So as we already said, this trigeminal neuralgia, the root cause is the compression of the trigeminal neuralgia by the either any artery or the vein. So the most commonly it is giving a pressing or compression by the superior cerebellar artery. So since the superior cerebellar artery is compressing the root of the nerve, that will increases the pressure within the nerve. As a result of this compression, the pressure within the nerve will be increased and there will be a focal demyelinization will happen, and this will make the nerve fibers hyperexcitable. And due to this hyperexcitability, even a light touch what will happen means the nerve fibers will start firing, very much firing in response to that light touch. That is resulting in the brief episodes of intense pain. So due to the compression, the nerve or the pressure within the nerve will be increasing, and it is causing the focal demyelinization and hyperexcitability of the nerve fibers. And it will start firing in response to the light touch that will be happening, and that will result in a brief episode of intense pain. Next, moving on to the clinical features. As we already said, the pain is the main characteristic feature of trigeminal neuralgia. And the pain is mainly occurring in the areas of the face where the trigeminal nerve is supplying the normal sensation. So wherever the face get the adequate supply from the trigeminal nerve, these are the areas which is where the person is exhibiting the pain. So it includes the cheek, the jaw, the teeth, gums, lips, and sometimes the eyes and foreheads are also the areas where the person is exhibiting the pain. And the pain is described in trigeminal neuralgia as a stabbing pain or an electric shock like burning, crushing, and exploding type of pain. It's a characteristic feature of pain the person is experiencing in patients who are having this trigeminal neuralgia. And this pain will be lasting for a few seconds to minutes. So it depends upon the person and the conditions and how much there is a remission or exacerbation of the condition. Based on that, the pain will last either for a few seconds or 2 minutes. And the pain is usually exhibiting in the unilateral. Predominantly on the right side, the pain is exhibiting. Then this is always precipitated by the triggering zone. So we have already discussed about the various triggers or triggering zones, and this will precipitate the condition. Then in patients who are having extreme cases, they'll be having a frozen or mask-like face will be there. So that is in the extreme case of trigeminal neuralgia. Then next, regarding the diagnostic test, the main focus is on the history collection. So we have to collect the pain history from the patient. What are the chief complaints of the patient? What are the history of the presenting illness? What are the current symptoms? That is, what is the onset? What is the location, quality, intensity, frequency of pain, duration, any aggravating or any alleviating factors? What are the past treatment the patient has taken? All these history need to be collected in patients with trigeminal neuralgia. Then under the physical or the neurological examination, the main focus is on the trigeminal reflex testing. So it has both sensory as well as the motor function. So we can check the sensation in the neurological examination. We can check the sensation with the help of a cotton tip, or you can do both the reflexes like corneal reflex and Georgia reflex can be tested. Then computer tomography and magnetic resonance imaging, both are used to find any structural lesions or vascular compressions which may be the cause for the trigeminal neuralgia. So to identify any secondary cause for trigeminal neuralgia with the help of this computer tomography or the magnetic resonance imaging. Next, we'll be discussing about the management. So, both the medical as well as the surgical management is available in patients with trigeminal neuralgia. And the treatment that is broadly classified into two forms, that is a destructive treatment and the non-destructive treatment. So, under the destructive treatment, it includes radiofrequency rhizotomies, balloon gangliolysis, and stereotactic radiosurgeries. And there are certain possible complications which is associated with these destructive treatments. And it mainly includes the facial numbness may be present, then neuroparalytic keratitis, or the person may have the severe complication of anesthesia. All these are the possible complications if the patients undergone the destructive treatment. And in case of the non-destructive treatment, it includes mainly the medical treatment as well as the microvascular decompressions. All these will be discussing in detail. So under the medical treatment, so the main drug of choice is the carbamazepine. So it is an anti-seizure medication, which is the main drug of choice in patients with trigeminal neuralgia. So this will be given at a dose of 100 to 200 mg twice daily or thrice daily. So under the medical treatment, the main drug of choice is the carbamazepine, which will be given at a dose of 100 to 200 mg twice or thrice daily. So this will be providing benefit to a more than 75% of the patients. This carbamazepine is beneficial. And the mechanism of these mechanism of action of these carbamazepine is that it will be causing the modulation of the voltage-gated sodium channels that lead to a decrease in the neural activity. So in order to reduce the neural activity, this will help in modulating the voltage-gated sodium channels. So that is the mechanism of action of carbamazepine. And other than the carbamazepines, we can use various other medications like oxcarbazepine, gabapentin, lamotrigine, baclofen, topiramate, sodium valproate, phenytoin, clonazepam, and pregabalin. So these are the other medications we can opt. All these are like anti-seizure medications which can be used in the treatment of trigeminal neuralgia. And the possible complication of this non-destructive treatment is the side effects of all these medication, or these patients are more chance or more risk for surgery. So this is the possible complications under the non-destructive treatment. So next we'll be going to discuss about what are the surgical management available in patients with the trigeminal neuralgia. So surgical options are mainly reserved for patients who have a clearly defined secondary cause for trigeminal neuralgia. If the person is having a secondary reason for trigeminal neuralgia, they'll be undergoing the surgical management. And those persons who are unresponsive or those who have severe unremitting pain that limits their ability to eat, so that will be affecting their nutritional, there will be a nutritional imbalance for that person. So that persons we can go for a surgical option. And those persons who cannot tolerate any multiple medications, they are intolerable, or if there is any contraindications for taking multiple medications, those patients also will be opting for a surgical management. So these are the persons we can do a surgical correction. So the various surgical options include the percutaneous glycerol rhizolysis, then percutaneous balloon compression, then radiofrequency trigeminal rhizotomy, gamma knife radiosurgery, and microvascular decompression. So these are the surgical options that we are opting for patients who are doing the surgical management. So we'll be discussing one by one in detail. So first we will be discussing about the percutaneous glycerol rhizolysis. So this procedure, it is mainly used in arterial or venous compression of the trigeminal nerve. If the trigeminal nerve is compressed by either an arterial or venous, that will be, for that patients will be doing this percutaneous glycerol rhizolysis. And also in case of the demyelinating disorders like multiple sclerosis, this procedure is used. And with this type of rhizotomy, a surgeon will use a needle to deliver a small amount of chemical to the affected nerve root. So whichever the nerve root that is being affected, to that nerve root, a small amount of chemical is being induced by the surgeon. And this is always done under the fluoroscopic guidance. And moreover, the solutions that we are commonly, or the chemical that we are using is either an absolute alcohol or a phenol or an alcohol phenol mixture that will be injected into the trigeminal system. So this procedure is delivering a small amount of chemical to the root of the affected nerve under the fluoroscopic guidance into the trigeminal system. That is percutaneous glycerol rhizolysis. The next one is the percutaneous balloon compression. The percutaneous balloon compression, the main purpose of this procedure is to compress the trigeminal nerve to disrupt the pathway that causes the pain. So the purpose of this procedure is mainly to compress. We have to compress the trigeminal nerve so as to disrupt the pathway that causes the pain. So we usually uses a pear-shaped balloon for this procedure, and moreover, the compression time is 1 to 7 minutes. And this procedure is done under the general anesthesia, and moreover, under the X-ray, a needle will be introduced through the cheek into the trigeminal nerve by using an opening in the skull. And a skull opening will be made. Then the balloon will be expanded once it reaches the trigeminal nerve. The balloon will be expanded, and the compression was given for a time period of 1 to 7 minutes. And this will compress the nerve. So most patients will experience some degree of numbness after the procedure. So the numbness, which indicates that the nerve has been successfully damaged to prevent the trigeminal neuralgic pain to reach the brain. And that is the main aim of the study. We have to successfully damage the trigeminal neuralgic pain to reach the brain. So in this case, a needle will be introduced through the cheek into the trigeminal nerve by an opening that is made in the skull called the foramen ovale, and this balloon will be expanded. The pear-shaped balloon will be expanded in order to compress the trigeminal nerve, and a compression or time of 1 to 7 minutes will be provided until the nerve get damaged. So it is one of the destructive procedure. Next, we'll be discussing about the radiofrequency trigeminal rhizotomy. This procedure, it is performed by placing a needle in the Gasserian ganglion. So Gasserian ganglion is the point where all the maxillary, ophthalmic, and mandibular branches will meet together. In that Gasserian ganglion, we will place a needle into the Gasserian ganglion, and through which an electric current will be passed. So these electric current, it will be starting with a volt of 10 volt, and we can increase up to 20 volt. Okay, this is given at a duration of 13 to 40 seconds, and that will produce a thermal lesion in the ganglion due to this electric current, which is passed through the needle into the Gasserian ganglion, which will produce a thermal lesion within the ganglion. So this radiofrequency rhizotomy, the theory behind the use of radiofrequency is that this radiofrequency will selectively destroy only the unmyelinated or poorly myelinated nociceptive nerve fibers, and it will spare the myelinated fibers, because these myelinated nerve fibers they will be doing the severe touch, proprioception and motor functions will be done by the myelinated fibers, and these radio frequency will selectively destroy only the unmyelinated or the poorly myelinated nociceptive nerve fibers, so that the functions like touch, proprioception and motor functions will remain intact. So that is the theory behind the use of this radio frequency rhizotomy. And moreover, this radio frequency rhizotomy, it can be used for patients who are elderly or medically frail patients. This radio frequency rhizotomy can be used. So next we'll be discussing about the gamma knife radiosurgery. It is a focused array of 201 intercepting beam of gamma radiations, which is produced by separate cobalt sources. So 201 intercepting beams of gamma radiations are being produced by separate cobalt sources, and the dose is usually 70 to 90 Gauge. And the mean time to pain is the pain relief will not be happen immediately after this gamma knife radiosurgery. So even though the beams of gamma radiation has been provided, there's separate 2 or 3 times we have to do the same procedure, and approximately the pain relief will be happening only within 1 month after the commence or after this procedure. Next, we will be discussing about the microvascular decompression. It is the classical and most effective surgical procedure that directly addresses the underlying pathology of classic trigeminal neuralgia. We have already discussed that the main causative factor for this trigeminal neuralgia is the compression of the trigeminal nerve root by the artery or the vein. So that is the underlying pathology for a trigeminal neuralgia. So this microvascular decompression, it will decompress the artery. So it is directly addressing the underlying pathology of classic trigeminal neuralgia. So the approach is usually the retrosigmoid craniectomy approach. That is, it involves a posterior fossa craniectomy and dissection of vascular elements that compress the trigeminal in the subarachnoid space. Whichever the artery that is compressing the trigeminal nerve will be decompressed in this procedure in the subarachnoid space. For the decompression, they'll be using a Teflon felt. Teflon felt is used to pad the nerve away from the artery or the vein. So the artery and the vein will be separated by a Teflon felt, which is keeping between the artery and the nerve, so that the compression can be relieved. And it is done in a retrosigmoid craniectomy approach. And for the younger, healthier patients who can tolerate the longer, more invasive procedures, they'll be doing this microvascular decompression. So microvascular decompression is an option for patients who are healthier, young, who are tolerable for this long surgery. A Teflon pad will be kept in between the nerve and the artery, so the compression of the nerve can be relieved, and as a result, the trigeminal neuralgic pain due to the because of the compression of the nerve can be reduced. There are also other procedures other than the surgical management, such as peripheral procedures can be provided, like peripheral neurectomies can be done, or cryotherapies can be provided, alcohol block, or any streptomycin lidocaine injections can be provided. So these are the peripheral procedures which can be done other than the medical as well as the surgical management. The next we'll be moving on to the nursing management. So the nursing management mainly focus on the pain. The main characteristic features of the trigeminal neuralgia is the chronic pain. So what are the management we can do in order to reduce the pain of the patients we need to identify? And moreover, the patient will have the imbalance in nutrition because the person has the difficulty in eating and chewing, because eating and chewing are considered as triggering zones which will exacerbate the condition. So we have to take special precautions to provide the diet where the patient can be tolerated. So we'll be usually giving a low fat, high protein, high caloric diet for the patient, and those diets which are easily chewable for the patients. And we can serve the lukewarm water and should not give a heavy food. We have to give it frequently. Light foods has to be provided, which should be given offered frequently. And we have to always avoid extreme hot or cold, hot sauce, chili, spicy, mints, black pepper, cinnamon, ginger, nutmeg. All these foods need to be avoided in patients, the trigeminal neuralgic patients' diet. Then patients will always have the fear and anxiety due to this condition because of the exacerbation of pain or intense pain. So we have to encourage the patients to take all the actions in order to reduce the pain. Thank you.